This this is 6-month-old child presented with lethargy and extensive crying. So babygram was taken and skeletal survey was performed. Okay, so you can see here that there are extensive lytic lesions involving all visualized bones. If you can see here within the hand, you can identify multiple lytic lesions. Similarly, you can identify multiple lytic lesions in long bones. There is pathological fracture here in the distal femur, tibia, fibula, even small bones of the feet. And you can also see multiple lytic areas within skull. So differential diagnosis, the first differential diagnosis for this imaging appearance would be metastatic deposits, metastatic bony deposits from neuroblastoma. And other differential would also include metastasis from some other primary malignancy. Further workup ke liye definitely we will see for, we will do imaging in chest and abdomen with contrast, CT contrast to find out the neuroblastoma origin and to find out the primary. So this is second case. This is young gentleman and had long-standing history of knee pain. So we always start from plain film and then further imaging workup. So you can see two images, AP and lateral view of the knee joint and then MRI imaging. So we can see here that there is a circumscribed lytic lesion, expansile lytic lesion in subarticular location of the right proximal tibia, which has eroded the lateral cortex of the tibia, and there is probable a soft tissue which is associated with this lesion. On MRI imaging, you can see the soft tissue itself, and you can see the avid enhancement of this soft tissue lesion. And it has also infiltrated the adjacent musculature of posterior compartment. So the diagnosis on plain radiograph, differential diagnosis on plain radiograph would be giant cell tumor and probable malignant transformation. And you can confirm it on MRI. And there are some, you can also appreciate there are some internal cystic T2 hyperintensities. Actually, these T2 hyperintensities usually represent underlying aneurysmal bone cyst. Or usually these lesions are a mixture of GCT and ABC. So there are some, there may be some fluid levels as well. So the spectrum of disease is giant cell to ABC or ABC to giant cell. But the diagnosis, this is confirmed diagnosed case of giant cell tumor with malignant transformation. So here we can see a large exophytic expansile mixed sclerotic and lytic lesion arising from the lateral border of this left scapula. It has some chondrite internal calcifications. And there is also expansion of the left proximal humerus. So differential diagnosis or first differential would be multiple exostosis on this film. This one is pedunculated exostosis, and the one which is arising from the medial border of the left proximal humerus is sessile exostosis. So this is case of multiple exostosis. This is one of the favorite cases in the spotting or Viva. Okay. Now come to the next case, case number 4. So this was this is the recent case, and this was a 9-month-old boy with a painless swelling at the ventral aspect of the right foot, and we did the ultrasound, and you can see. So we can see here a large swelling at the ventral aspect of the right foot, and on ultrasound there are multiple internal cystic areas showing both type of blood coming in and out, and there is a flabulate. There are a few flabulas sitting within this lesion. So this is a typical imaging appearance of slow flow vascular malformation with first differential diagnosis of venous malformation. 9% venous malformation, not hemangioma. Okay, so this is a case of hemangioma. Okay, the flabulous in childhood means venous malformation. Flabulous in adult patient usually represent hemangioma. Right shoulder MRI, multiple images. So here we can see that in the superior labrum there is a defect, okay, which can be appreciated on sagittal, coronal T2 weighted images as well, and on proton density fat saturated coronal image you can also see this defect in the superior labrum. Okay, this is sagittal image, and you can find here that there is also abnormal high T2 signal intensity within the substance of the long head of the bicep muscle at the site of its insertion. And similarly, similar finding you can see on T2 weighted image. So diagnosis is superior labrum antero posterior tear, slap tear. Okay, so this is the case of slap tear. Very typical. You have been provided with a plain radiograph, CT scan, and the intervention. So this is a typical imaging appearance of osteoid osteoma. You can see laminated thick periosteal reaction along the medial aspect of the left mid diaphysis of the left femur, which is again seen in the CT scan, and there is a lucent nidus with central high density. Okay, and as we all know that nowadays the gold standard treatment of osteoid osteoma is radiofrequency ablation. So this is the radiofrequency ablation needle which is inside the nidus. We target this nidus or lucent area, and if it is ablated completely, then the treatment is completed. So this is post ablation defect. Okay, so this is next case. This is 20-year-old male with severe anemia. So look at the appearance of the long bones. You can find that there is permeative lucencies within the metadiaphysial region of tibia as well as fibula. There is some sclerosis. Soft density, but the amazing thing or striking thing here on MRI is the density or signal intensity of the long bone. This is not usual. This is very dark or hypointense bone.
Okay, what is the difference between venous malformation and hemangioma?
Okay, hemangioma is a mass. Okay, whereas venous malformation is a vascular malformation. Okay, and vascular malformations are divided into high flow and low flow vascular malformations. In low flow vascular malformations, there are three types: venous malformation, lymphatic malformation, and veno-lymphatic malformation. Whereas hemangioma is a mass, it's a neoplasia of soft tissue, which contains vessels. Okay, so there is a difference between these. Hemangioma is a dyneoplasia, whereas venous malformation is a vascular anomaly. So, number 1 is AVM, number 2 is AV fistula, number 3 is aneurysm, number 4 is pseudoaneurysm. So everyone can see that there are multiple lytic lesions and there are beveled margins. These are called beveled margins. Okay? And these are geographic in appearance. Okay? And these are multiple in skull. So first differential diagnosis is eosinophilic granuloma. Okay? Histiocytosis X. Okay? Otherwise, the brain parenchyma is normal and there is no obvious abnormality on contrast CT scan. Okay, so this is the case of Langerhans cells histiocytosis. Since long. जब हमने एक्सरे किया तो there was a flabulet, then we did ultrasound. On ultrasound, there were more than one flabulets. One is here and the other one is here. And there was no significant internal vascularity except minimal along the septations. And on MRI contrast study, this was a lobulated mass with a small flabulet. This is a mass with flabulets in adult patient. This is likely a hemangioma. Internal septa with narrowed zone of transition, no periosteal reaction or soft tissue. And on MRI, it is ISO 2 hypointense on T1, very hyperintense on stir image, and showing post-contrast enhancement, patchy post-contrast enhancement. This is stir and this is post-contrast T1 fat set. So differential diagnosis for this. So this is a case of non-ossifying fibroma. Lateral view of left femur and MRI contrast study of the same patient. This is T2 weighted image and this one is post-contrast T1 fat set image. Okay.
So the in first two sequences, first two images, these are the plain radiograph of the left hip joint involving the femur, in which I can see that there is ill-defined lytic area involving the proximal metadiaphyseal region of the femur with underlying tubulation of the bone, and it has wide zone of transition causing some cortical expansion also, with adjacent some soft tissue thickening is also evident. No cortex mineralization is evident, sir, in it. The bone is also bowed because of this lesion. As it is involving the metadiaphyseal region, on this plain radiograph, I would like to say it as a ask the patient age and put it in the diagnosis of fibrous dysplasia, because it has no matrix mineralization and showing some ground glass haziness, sir.
Okay, so zone of transition in fibrous dysplasia is widened or limited or narrowed?
Sir, although it is limited, sir, but if it is involving polyostotic and sir, it may be wide zone, sir, also. Next, I will.
Well preserved, and that distal diaphysis is also preserved. So the zone of transition is very limited in this case as well, but due to large size of the fibrous dysplasia, it looks that the zone of transition is widened. But if you look at the proximal and distal segments which are spared of the left femur, the zone of transition looks very limited. So this is definitely case of fibrous dysplasia.
Yes, sir. On MRI, I can say, but on X-ray, sir, it was showing wide zone, but with cortical expansion. That's why I put it in the case of in diagnosis of fibrous dysplasia.
I'm provided with multiple sequences of MRI knee. These are T1, T2 fat set, and PD fat set images, T2 sagittal, and T1, and again there is a T2 sagittal fat set and T1 image. I can see there is non-visualization of anterior cruciate ligament in all these images, and there is deepening of the notch in the sagittal image and the coronal image. Sorry, there is also a tear. Meniscal tear is also noted uh, on the anterior and the posterior horn. Further, I think there is a double. There's a looking at the first image, I can see that there is a. Let's say, okay, let me go through the images.
What's the meaning of double PCL sign?
So the double PCL means that either the anterior or the posterior horn of the menisci has been detached from its place, and it flips together, and it's placed inferiorly to the posterior cruciate ligament.
The partial tear है. देखिए anterior half is well visualized, but the posterior fibers are blurred. Okay. Then ये क्या?
So this is a loose body seen within the intercondylar notch. So it's a fracture of the interspinous the spine of the tibia, where the attachment of the ACL.
Multiple findings. This is a case of trauma. There is a fracture of the tibial plateau. There is associated partial acute tear of the ACL. There is double PCL sign representing bucket handle tear of the medial meniscus. And if you can see here on coronal image, the tear is also visible.
Yeah, okay. Meniscal tear. Okay.
Young patient was presented with history of acute right hip pain. Okay. This was a case of acute right hip pain, and this is young male. So we can see here that there is abnormal signal intensity in the subarticular location of the right proximal femur, which is extending into its neck and the proximal diaphysis. So there is no irregularity of the contour of the femoral head, no underlying fissure, and there is minimal or mild joint diffusion. So that transient osteoporosis of the hip joint. Transient osteoporosis of the hip joint. Then most of the time it's self-limiting. Okay. So hyperintensity in subarticular location doesn't always mean that there is avascular necrosis. Many times it's transient osteoporosis of the hip joint. Okay. Patient with shoulder pain, chronic shoulder pain, and CT was done for the primary diagnosis. And everyone can see that there is a circumscribed expansile lytic lesion arising from the medial border of the left scapula. And on reconstructed images, you can see that there are so many internal laminations and septi, bony septi. Okay. So this was differential diagnosis for this would include aneurysmal bone cyst and fibrous dysplasia. Okay. And actually this was the diagnosed case of aneurysmal bone cyst, biopsy proven. Okay. So this was a young lady known to me, presented with chronic pain at the lateral aspect of the elbow joint, and this was her MRI. So you can see here that there is focal hypersignal intensity within the conjoint tendon, extensor tendons on fat suppressed proton density image. And if you see the high frequency ultrasound, comparison has been made. This one is right and this one is left. And this gap is of the elbow joint. So you can see that there is obvious thickening of the conjoint and extensor tendon when compared to the left side. Left side ka tendon is very smooth and you can see the fat, then tendon and the joint. But here you can see that the fat is thickened and blurred, then the tendon, conjoint tendon, extensor tendon itself is thickened, and you can also appreciate a focal hyperechoic area which is actually representing focal calcification. So this is a tennis, this is a case of tennis elbow. So another case, a very interesting case, X-ray shows marginal erosions in the periarticular location in multiple joints, small joints, especially the metacarpophalangeal and the interphalangeal joints. Okay, all these erosions are highly suggestive of seronegative spondyloarthropathy like psoriatic arthritis, or even can be seen in cases of RA. Okay, concomitant ultrasound, you can see here that this is a joint, metacarpophalangeal joint, and you can see this black area which is actually the hypertrophic synovium. Okay, and on Doppler scan you can find that there is a lot of vascularity within this synovium. Proliferation hai, or there is increased vascularity. So this is active arthritis, inflammatory arthritis. This was a case of psoriatic arthritis. Okay. So next case again. So MRI is being compared with concomitant ultrasound. Okay. So on MRI, it seems that there is tear in the leading tendon of the supraspinatus muscle. Okay, this is the leading tendon of supraspinatus muscle, and it is absent here at the site of its insertion, and rather replaced by presence of fluid signal intensity. Okay, there is some osteoarthritis in the acromioclavicular joint and slight joint diffusion as well. Okay, superior labrum is okay. So it was considered that this is complete tear of the rotator cuff or supraspinatus muscle. But now see the importance of ultrasound shoulder. On concomitant ultrasound, we can see here a defect in the leading tendon of the supraspinatus. There is a defect which is fluid containing or hypoechoic on ultrasound, representing partial tear of the leading tendon of supraspinatus, rather complete. Was presented after RTA with numbness and loss of functionality of the right upper arm. If you see, there are the perineural sleeves here arising from the lower cervical region, likely C4, C5, C5, C6, C6, C7, all these are thickened. Okay, on fat suppressed coronal T2 weighted images, you can see the thickened nerve roots arising from the spinal cord extending into the right axillary region. This is the brachial plexus, and if you compare the signal intensity of this brachial plexus to the left side, it is obviously abnormal. So there is high chances of injury to the brachial plexus at its origin after originating from the spinal cord, spinal canal. So this was the case of trauma, and there is brachial plexus injury. Ever angle is nearer to the surface of the probe. Okay, this is beta angle. Yeah, away from the direction of the probe, this is alpha angle. Both angles are abnormal, 32 and 94. Dusri taraf 58 or 51. So this is definitely abnormal. How much percentage of head of femur is under cover to the labrum? So more than 50% should be covered under acetabulum. In case of trauma, okay, so you can see here blurring of margins, abnormal signal intensity, abnormal orientation of ACLs, so almost complete tear of ACL, significant subarticular edema. Okay, and radial tear in the medial meniscus, okay, sorry, lateral meniscus, and a parameniscal cyst, okay, and joint.
This is the axial slices of the CT, in which I can see on bone window multiple lacunar defects are seen along the temporal region of the bone, which are like defective defects on soft window along the right temporal region. I can see that there is hypodense area which is involving the temporal region. Um, on another section, I can see that there is well asymmetry between the two temporal areas. Sir, I would like to ask the history of the patient and the age of the patient, and then yes, sir.
6 years.
6 years, sir.
Yeah.
Sir, it appears aggressive lesion with soft tissue component and having bone defects. I would like to put it in the case of MET, sir.
Okay. You see here, there are symmetrical soft densities, enhancing soft densities, replacing the greater wing of sphenoid bilaterally. And you can see here some erosion of the bone extending from the temporal region to the petrous part of the temporal till the occipital. And these are geographic lesions. And some have.
So then these are eosinophilic granulomas, sir.
Okay, so this is the case of eosinophilic granuloma. There are three differential which always go side by side. One is eosinophilic granuloma, the other one is Ewing sarcoma, and the third one is osteomyelitis. So this young man was presented with painful swelling at the posterior aspect of the thigh, and on MRI there was a circumscribed lobulated and fusiform shape abnormal signal intensity mass in the posterior muscular compartment, and it was hyperintense definitely on T2 and suspected to be a case of peripheral nerve fusion schwannoma. Okay, I did the ultrasound and now you can see that sorry, this is not thigh, this is actually arm, or this is anterior muscular compartment. Okay, so this was a lobulated abnormal signal intensity lesion suspected to be a case of peripheral nerve schwannoma, and now you can see the whole nerve and this lobulated mass arising from this radial nerve. Okay, and this was minimally hypervascular. So you can see here the importance of ultrasound over MRI, especially in the peripheries. A beautiful image of lobulated peripheral nerve schwannoma arising from the radial nerve. So this is normal bone, but definitely there is some sclerotic lobulated lesion within the metadiaphyseal region of the distal tibia, which has shown peripheral T2 low signal intensity ring and central hyperintensity. And on star image, you can see central hyperintensity without peripheral T2 hyperintense ring. So this is the case of bone infarct. And you can also see similar signal intensity lesion with subtle sclerotic margin in the medulla of the calcaneum. The case of SLE, okay, systemic lupus erythematosus, a defect in the articular surface of the medial femoral condyle, and on MRI this is actually an osteochondral defect. So this is a case of osteochondritis dissecans, expansile lytic lesions with chondrite calcifications. Okay, so this is case of Olier's disease. ठीक है, ओलियर्स डिजीज याद रखें कि टिपिकल हैंड में नहीं दिखाएंगे. ओलियर्स डिजीज ह्यूमरस में भी हो सकती है, ओलियस डिजीज पेल्विस में भी हो सकती है, शोल्डर के अराउंड भी हो सकती है। तो ओलियस डिजीज जो है मल्टीपल एनकॉन्ड्रोमास के साथ पूरी बॉडी में होती है।